Okay, it looks as though everybody's now sitting comfortably, more or less, apart from Sally. So let's make a start. Okay, welcome to Callington, and this is one of a series of 12 engagement meetings that is being held about the Acute Services Review and the Sustainability and Transformation Plan as a whole. Before I say any more about that, I'll just make a few housekeeping announcements. Firstly, many of you will be much more familiar with this hall than I am, but the toilets are out there off the lobby where you came in. There is no planned fire drill, so should the fire alarm go off, then clearly the exit's marked with the usual green running person as the way to go, either through there or back through the main door where we came in. And there are refreshments, which I'm sure many of you have seen over in that corner of the room. You're welcome to partake of those at any point during the meeting. Right, I'm just to introduce myself. My name is David Rogers. I am the Vice Chair of Healthwatch Devon, and I realise the sensitivities of the Tamar, so you know I hope I'm welcome here this afternoon. What Healthwatch is the independent consumer voice for all those who use health or social care. And we've been asked to chair these meetings because we're independent in that sense. We're not part of the commissioning organisations nor part of the provider organisations, and therefore we, if you like, can see both sides. We can represent public views, but we also understand why the organisations within the NHS, and for that matter within the local authorities, are involved in the process that they are engaged on. What we're going to do this afternoon is to introduce the Sustainability and Transformation Plan as a whole, and specifically the Acute Services Review. And my colleagues here on the panel will be doing that in a few minutes, led by Anne James. I'm sure she'll say more about herself then, and also introduce her colleagues. And so we'll hear about the STP as a whole thing, and that people understand the principles that underlie it. Most of those are outlined on this board here, and you'll be hearing more about that. And then more specifically about the Acute Services Review, which is the stage or the element of the STP which is being which is the purpose of this meeting. What we then want to hear from you is any questions or comments that you have immediately. That'll follow the presentations. There'll be at least 30 minutes for questions and answers from the panel. And then there'll be discussions around each of these tables for perhaps I don't know how to characterize it, but quieter, more considered, more reflective views and comments to be expressed, and there will be facilitators on each table to make a note of what points you want to raise, and for those to be answered if that's at all possible. So I think that's probably all that needs to be said at this stage. Of course, it's my role to keep us more or less to time, so 20-25 minutes for the presentations maximum, 30 minutes minimum for the question and answers, and then the rest of the afternoon will be these roundtable discussions that I've just described. So thank you for listening to that first bit, and Anne James, over to you for the presentation.
Okay, thank you very much indeed. Good afternoon, everyone. Thank you so much for coming along today. So what we're going to do this afternoon is just talk you through the Sustainability and Transformation Plan, and in particular, the aspects around Acute Services Review. Now, just to keep the flow going this afternoon, I'm going to give the presentation, which I hope you can all see. But obviously I've got the support of my colleagues. So what I'm going to do now is just ask them to introduce themselves, say a little bit about what they do, and then when we get to questions, you know who they are and perhaps who you'd like to direct those questions to. So Rob, can I perhaps start off with you?
My name is Rob Sainsbury, and I'm the Chief Operating Officer at New Devon CCG. So that's the clinical commissioning group that's responsible for setting what we would call the commissioning intention or direction for the strategy for Devon. So we work with all of the other organisations, the trusts, GPs and the broad health services and our partners in social care to kind of set that strategic direction, and then our partners deliver it for us.
Thanks, Rob. Hello all, my name is Carl Trimble. I'm an orthopaedic surgeon from Plymouth. I'm also one of the associate medical directors involved in transformation and project design, and I'm working quite closely with the rest of our provider partners across Devon in redesigning healthcare and frameworks.
Hello everybody, my name's Sheila McCormick. I'm a GP in Plymouth now, although I was a GP just down the road in Gunnerslake for 12 years. So I know all about the challenges that this part of the world has and how we relate to Derriford in particular. So I'm here representing the clinical commissioning group today as a clinical lead.
Okay, thank you. So I'm Anne James, Chief Executive of Derriford Hospital in my day job, but here this afternoon to just talk you through some of the things that have been happening on the Sustainability and Transformation Plan, and looking forward to a discussion about some of the issues that you think are affecting you. So what we really want to do is to just explain what the whole context of the sustainability, known as the STP for Devon, is about. Looking in particular about acute and hospital services, and then we're going to, through questions and answers and discussion, just get a sense about your views, what the issues are, and what you'd like to hear more about. So if we go to the national context, it's really important that you're aware that in the last year or so, nationally, we've introduced something called Sustainability and Transformation Plans, STPs for short. Not a very catchy title, I know. And so the Devon STP is one of 44 across the whole country. And really the whole plan and the thinking behind STPs is to make sure that we all work together to plan the most effective services to meet your needs in the longer term. And importantly, it starts to bring together health and social care in terms of our planning, because we know how important that is to meet the needs of individuals. And we're really confident that there's going to be a number of important benefits by working together and making sure that we plan properly. And that's making sure bringing health and social care together, addressing some of our particular needs in this part of the world, and that includes an ageing population. But having worked in Cornwall for a number of years, the geography is also a big issue, and access to services. How we start to meet some of the demand that's being generated for care, making sure that that's the right care at the right time and in the right place to meet those needs, and also just making sure we maximise the use of technology to really help us as we move forward in planning those services. So what's really important for the Devon STP is that this isn't just about one organisation. This is about all of the organisations, health and social care. They're all listed there and described, that we really start to work together, and that our focus, we are united in making sure that together with you as our true partners in health and social care, we plan for the future in a way that makes our services for the future and for future generations most effective, clinically sustainable, and importantly affordable for the money that we've got. So let's just think about the aims of the Sustainability and Transformation Plan, and there are three key things that we're really focusing on trying to do. One is about improving the health and well-being of our population, delivering safe, high quality and effective care, and making sure that that effective care is also making best use of every pound that we've got. So if we think about the health and well-being of our population, we know that we've got an ageing population. We know that the needs that they have is really putting a high level of demand on all of our services. But we also know that there are significant health inequalities across Devon, and that is both about where you're born, the issues of deprivation, but also some issues of access and rurality that we know is a real challenge for this part of the world. So it's all about what can we do to really support people's needs early on, early intervention. But when we're looking at delivering safe and high quality services, we also know that there's real variability in different areas, and variability that can't always be justified. And that is really important that we have a look at that. I think most significantly, we are all, as NHS and social care leaders, absolutely united that people's mental health issues are just as important as people's physical health. And we really need to make sure that we are thinking of each and every citizen as a whole person, not dividing them up to their particular needs. And importantly, is about recovery and support, and the principle that your own bed is the best bed, even if that requires some support, I think is something that we would want to take forward, but also the evidence for improving outcomes is also there. And then the final component, which I think is also really important, is about financial sustainability. We're going to show you a little video in a moment, but if we carry on the way we are with the current pattern of services and what we know about the demands of the population, what technology will drive and how we need to meet people's needs, if we don't change the way in which services are being delivered and accessed, then by 2020 across Devon, which includes South Devon and Plymouth, then the financial gap alone will be pushing £557 million. So 2020 is not that far away. And we know if we don't get our money in order, then that in itself has a huge impact on clinical services. The two have to really be in balance, and that is a real challenge that we want to address through this STP process. And importantly, where we've got health inequalities across Plymouth and Devon, we also have some financial funding inequalities. So making sure that at the end of this process, we've got the right services in place to meet the needs of the people that we're serving, and the money follows that, is really, really important. And there's some of the fundamental principles that are underpinning the STP. So within, have we missed the video?
Yeah, it was before the
Should we do it in a moment then? So what we're going to do in a moment is show you a video which then, through the words of some of our local citizens and our staff, describes that in a way that really brings it alive. And what they'll talk about is that through the STP, we've got 7 priority areas. So just to recap, it's making sure where we can that we avoid ill health around prevention, early intervention, health and well-being and support. That we then start to provide really integrated care around community primary care services and that interface with health and social care. Mental health then being really important, and I think we'd all acknowledge we can talk about physical health a lot. Mental health needs to absolutely be there on the agenda. It affects everyone, whatever our age or social background. And we're going to talk a little bit more in a moment about the acute hospital and specialist services, but children and young people, obviously fundamental. And what we do need to do is to make sure that our services meeting the needs are done as efficiently and effectively as possible. So I'm just going to pause there and show you a video which I think really brings that to life. Yes, of course. Yes. That will be the total. That is what we will run with if we don't change anything else.
So that's over the next 4 years?
Yeah.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care. There are 400,000 local people living with one or more long-term conditions, and their needs are complex. Around 150,000 people have a mental illness. Doing nothing is neither affordable nor clinically sustainable. We will be more than £500 million in the red by 2021 if nothing changes. Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people. These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on health care for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospital, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition. People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly specialist placements, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget but still achieve poor outcomes. They're also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care can get the best possible outcomes for local people.
So I think that video clip really does set out the scale of the challenge that we're facing and the one that we're trying to address through the STP. But I want us now to just focus on one aspect of this. So I said a few minutes ago that there are 7 areas, priority areas that we're looking at. This afternoon, I'd like us to just look at one area, and that's around acute hospital and specialist services. Now, for all the reasons that have started to be highlighted in the video, we're looking at 3 areas across all of the hospitals. Urgent and emergency care, stroke services, maternity, paediatrics and neonatology services. And the reasons why we're looking at those 3 as opposed to any others is set out there. So we know that there is increasing demand and need for those treatments, and we know that our waiting times are getting longer. We also know that our services were designed at a point that is some time ago now. If we were starting again, we would organise them very differently to how they are now. And that's because technology has changed, the needs of the population has changed, and we've now got new innovations like new drugs, new clinical standards that we need to comply with. And what we also know is that workforce is a real challenge for us. We can't get all of the right staff that we need to support the services we've got. We're therefore struggling to deliver 7-day services. And you will know, I'm sure, through your own experiences, that we're really struggling to meet some of the current national standards around waiting times. So I just want to tell you a little bit about each of those areas, because we've started to do some work now about what the issues are, what are the options for those for the future, and what do we want to really make sure that we get your input in at a very early stage. And it's your input that we really want to focus on in a moment. So I'm just going to run through these fairly quickly. So for each of those areas, we have a medical director running each of those groups. So for urgent and emergency care, we've got Adrian Harris, who's the medical director of the Royal Devon and Exeter, and he has a group that then has clinical representation from right across Devon to input into those discussions, to think about and really understand the challenges and what might the different scenarios be as we go forward. The real challenges then are how we meet the standards that we now have for 7-day services, how we make sure that we can address some of the staffing shortages, which are putting services under huge pressure, how we can really flex the different peaks in demand, how we meet the national targets. I'm sure you're all very aware of the 4-hour A&E target that we're nationally struggling to deliver. And how do we then make sure, with an ageing population, where people have got complex needs, that we get patients being cared for at the right place, at the right time, to meet their needs. And it's really important that we address inappropriate settings of care. So we know already that we have some patients in the hospital who would be more appropriately cared for somewhere else. So it's a huge agenda that that group needs to address. If we move on to stroke services, that is led by George Thompson. He's the medical director from North Devon. Again, has got representation from all clinical experts across Devon about how we take and address some of these issues. Again, workforce is really at the top there. We know we don't have sufficient consultants and nursing staff to sustain where we are on current stroke services, if we're also to then comply with the national guidance on best practice, making sure that we maximise people's outcomes should they have had a stroke. And we know with an ageing population, then we're getting more people having strokes. If we're to really maximise people's rehabilitation potential, if you've had a stroke, then we need to make sure you get to hospital quickly and you get the right intervention for your need, and that's why there's huge national publicity about the FAST process, to make sure that we get public support, to make sure people get to the right place if we think they're having a stroke. And making sure that that service is available 7 days a week is really, really key. And that's a slightly different set of challenges from the other group. So if we bring together maternity, paediatrics and neonatal services, so neonatal services are for babies that are born earlier than they should be, and they'll have lots of complex needs depending on how early they're born. That is led by Rob Dyer. He's the medical director of Torbay in South Devon, and again the same sort of model of involving a group of clinical experts to really think very carefully about the challenges, but what we might do as we move forward. So we know across all of these services, and we've put them together because they're very interdependent on each other, that we have real pressing workforce issues, so a lot of staff shortages. We're then using to run safe services agency staff, and agency staff are really expensive for the NHS, and what we don't get then is continuity of care, which is really important for newborns and their family, and that we're finding it difficult to retain 24/7 services because of the staffing problems, and that is really, really important for patient safety and continuity for the families. And this is heavily reliant on medical workforce as well, and we know that the number of trainees that are currently being trained, we're not going to have enough to sustain the current model. So we're having to think very differently about how we organise ourselves around those services, and it's really important that in doing that we are true partners with women to make sure, and families, to make sure that we give them appropriate and maximum choice. So that's a really important area. As well, with our population, we've got increasing, growing complexity and needs. So although we've looked at 3 really quite different types of services, some of the pressures that we've got are very, very similar. Now we're at a very early stage. These groups haven't been set up for very long. They're now just exploring some of the challenges that I hope I've described to you today. So what we want to do at this stage is really make sure that we align what is clinically important along with what is important to you as our local citizens, and that is really, really important to us. We need to get those properly aligned, and today is an opportunity for you to give some feedback to that. And we do want your views. I'm going to just run through the suggested areas now, but it will in a moment, through questions and discussion, be your opportunity to really input and change, give a good contribution to these. So we think some of the things before we start on the journey of getting anywhere near a decision is making sure that we've got the right criteria by which to make some decisions in the future, accepting that with the pressure and the scenario I've just described, there is no easy decision to be made. But we need to be guided by the things that are most important to you as citizens. So I'm just going to run through very quickly. Hopefully you've got these on your table as well. So, and these aren't in priority order. These are the things that together give us a proper decision-making framework. Whatever we want to do in the future, whatever decisions we make, that has to be done that they are safe options for delivery. And improving patient safety is really, really important. That any changes we make results in clinical benefit and improved outcomes, that is important. Access is key, especially given our geography. And this, whatever decisions we make in the future, we need to maximise the ability of patients and, importantly, carers to access those services. And that will mean us making some reasonable assumptions, decisions about travel time, balanced with best outcomes, and making sure that we can also deliver the waiting times that you need for any of the services that we've been talking about. If we're to start thinking about how we organise ourselves differently, any decision we make has to be sustainable. It can't be a decision that works for 6 months and then we've got to do it again. It's got to be able to be a bit more future-proofed. And that's not just about the clinical sustainability. It means we've got to be able to start confidently staff it, provide access, but it has got to be within the resources that we've got as well. We cannot continue to spend more money than we've got coming into the system. I've talked quite a lot about workforce. The doctors, the nurses, the support workers, all really key to running an effective service. So training them for the future is another key aspect of our decision-making criteria. Making sure that the service is cost effective is important. I'm sure we all do, that we could design services without thinking about the cost implications. But we've got to get the balance of the finance and the effectiveness of services absolutely right, because we know if we don't spend our money well and responsibly, that does affect patient care and outcome. Choice is really important for you, not just as patients, but as citizens, even if you're not yet using those services, and for the families of those who are. And ultimately, I think it's not just the outcomes that you experience, but it's what was your experience of using those services is also really important, and a way that you would tell us and tell me whether you think we've got good services in place. So hopefully I've set out the challenge around the sustainability and transformation plan and the way that we're trying to address those. We've had a focus in on acute and specialist services, and hopefully you feel I've run through some of the suggested clinical decision-making criteria that in the future, when we get to further engagement, making decisions, that we feel that collectively this is the right framework that we should be using. So we're now going to move, I think, to some questions. And thank you for your time.
Okay, thank you, Anne, very much for explaining that so clearly. Oh, yes, yes. Sam has just reminded me that the question and answers will be recorded. So if any of you, that's so that, you know, the points that are made can be fully incorporated into the later stages of the process. So if anybody is at all anxious about that, could you please speak, I think, to you, Sam, and then we can make arrangements to, you know, that you're not identified or whatever, if anyone is not quite sure about how they feel about that. Okay, well, what I just want to say before we start the questions and answers is that obviously we've heard a lot about Devon, and we're not in Devon at the moment. But the reason, which I'm sure is obvious to everyone in the room, is that Derriford is the acute hospital for this part of Cornwall, and therefore when we're talking about an acute services review, it's quite right that the Cornwall dimension of that should be taken into account. And just to add to that point, I mentioned at the beginning, I'm from Healthwatch Devon, which is the independent consumer voice for those who use health and social care. Equally, there is Healthwatch Cornwall. I'm not sure if any volunteers from Healthwatch Cornwall are here today. Anyone? No, I was informed that maybe there would be, but clearly they couldn't get here. But we are, you are, oh right, thank you. We are, as I said, that independent voice, which is why we're not part of any of the NHS groups or the local authorities. So I hope you feel that gives a slightly greater confidence to the way that these processes are undertaken. We're not endorsing any proposals that might come from this. We're acting independently. Anyway, without any further ado, let's go on to any questions or comments that you would like to make to the panel. I'll try to work my way around each of the tables so that everybody has a fair chance. You heard from the introductions who the various people are, so if your question is specific, then obviously it will go to the most relevant person on the panel who can answer that. If it's less specific, then maybe they're coming your direction, Anne, or the CCG, and you can decide for yourselves who you think is the most appropriate one to answer. What there won't be time to do, I don't think, unless we have very few questions, is for each of you to comment on each and every question. Okay, right, who would like to go first? A gentleman over there, and then I'll come to you.
Just a couple of points first. My name's Nigel May. I'm chair of the East Cornwall locality PPG umbrella group, which means we have representatives from all of the PPG reps from the practices in East Cornwall, or most of them anyway. Can I just say is that it would be really useful if people would like, who come from this area, because I'd like to keep a note of who's attended this for our own purposes, if in fact we need to communicate in the future with the New Devon STP. So it would be useful to ensure that you're brought into whatever the PPG's representatives are discussing. I would just like to say a first thing is that I found it quite disappointing that this is the first time an event has taken place in Cornwall relating to what's happening in New Devon. The broad aspects of the STP have obviously already been discussed, and certain aspects are proceeding already. I've been asking for some time to have some sort of meeting in Devon. Callington was the one meeting that was appointed. This is the only meeting at this stage that where we're discussing this, and I appreciate it's just the beginning of the process. But Callington, by the very nature of things, is not the major conurbations in this area, and neither is it very accessible to those people in North Devon. So having said that, I would hope you take that on board for future events, that we will actually have more than one consultation for Devon. Can I also say, and I won't continue this vein much longer, but when we see a document like this, which is, as you've recognise, is very much involving the Cornish population in North and East Cornwall, that the papers themselves, I appreciate they're only from about New Devon STP, but it would really be quite useful to have in there something that recognises that you are dealing with other people outside the area. It's all about what you can do for the Devon population. And it's not. It's about what you can do with people that are going to be using your facilities, whether they're in Devon or not. I mean, it could be Somerset for that matter. So I take that's my one point. I'm sure others will want to raise other more specific issues. Thank you.
And I think that one's heading in your direction.
Yeah. So I should have emphasised it a bit more at the beginning of the presentation, that we're here because of the catchment with Derriford Hospital. But I do get the point, Nigel, about needing to really link both the Cornwall STP and the Devon one and make it really clear about the issues that affect the population that perhaps look to Plymouth for some of its services. So just to assure people, I'm meeting with the lead for the Cornwall STP on Monday, who's the Chief Executive of Royal Cornwall Hospitals Trust, to really think about how we might do that more effectively, because we do need to fully engage the population on our boundary. But importantly, we need to then both be able to bring together for you as local people what our two STPs are saying about the services for yourselves. So that's something we'll absolutely take away.
Okay, I think that was a point well made, sir, so thank you. And you made the point, and Anna's made the point, that there is a Cornwall STP as well, and it's very important that the two should be talking to each other.
Thank you. Yes, I'm actually from Launceston, and I vote for a National Health Service. And someone should tell Simon Stevens that we're really bad, because not only are we all getting far too old and far too ill, but we refuse to use the NHS in line with the CCG boundaries. And I think the other thing that it's important that we bear in mind those boundaries is because the impact of what's happening, particularly in my area of Cornwall, is going to have a direct impact on what happens at Derriford. Because they're going to close the minor injuries units throughout Cornwall. They're going to close our community hospitals. Now, I live in Launceston. We're really lucky. We've got a car we can drive. If you haven't got a car, you're going to be in trouble. And what they're saying is your minor injury unit will close, but you can go to your urgent care centre. Now, rumour has it the urgent care centre for Launceston is going to be in Liskeard. Now, you ask any sensible person, are you going to... Well, you can't get the bus at weekends and bank holidays to Liskeard anyway, and I don't know how about bleeding on the bus and things like that. Are you going to drive from Launceston to Liskeard to go to the urgent care centre there, and then risk being redirected to Derriford? Or are you going to do the really sensible, leaves you two sensible choices. One, of course, is just to go straight to Derriford and cut out the middle person, which is going to have more of us turning up on your doorstep in Derriford. The second one, and nobody's mentioned them so far, is the ambulance service is going to become the sort of only accessible emergency health service to provide that urgent and emergency care to people actually throughout the whole of Cornwall, unless you're really lucky. And I think when Cornwall does and says, oh, we've got this very clever idea to have 3 UGCs and it will be much better because it's 24/7, ignoring the fact that a lot of people won't be able to get there, to ask your neighbour, you know, can you nip me up to the minor injury unit? My finger needs sewing up. Or can you nip me the 45 minutes to Derriford, sit and wait 4 hours and then nip back? So there's all of those problems going to impact. And lastly, what you said about problems in services, you know, all of the issues that are going on. I couldn't look at one of those issues and think, that's a good reason for cutting money off the budget. I couldn't see any of those that were arguments for anything other than more money for health services. Now, I appreciate that if you work for the CCG or for the NHS, apparently you're not allowed to say, Jeremy Hunt, you're a fool, there's not enough money. But I don't see that you can deliver what you're going to deliver in terms of services and the cuts at the same time. So that's up to people who don't, you know. But be honest with the local population and say you've got to fight for more money for the NHS.
Well, you've got the microphone there. I don't know which one's going to do it.
So I know Sheila wants to come in just about the urgent care one, which I think is really important. But what you've described around access is also really, really key. And that's why we've put that as one of the criteria for what we're looking at across Plymouth and Devon. I think that's really important. But again, I know we've got a colleague from Cornwall. Be assured that the points you've made will be taken away. And certainly when I meet the STP lead on Monday, I'll relay those to her. So again, they may want to come and talk to local populations a little bit more about that. But perhaps Sheila would like to say something about urgent care.
It's the urgent and integrated urgent care service that I wanted to just reference, because I absolutely take your point about the concerns that you have, but I think that an important missing part of the jigsaw in the integrated urgent emergency care service is that the 111 service will actually be able to point patients in the right direction. So in that situation that you described, where you didn't know whether you need a minor injury unit or an emergency department, if you were to access the 111 number, you would be able to speak to whoever was able to answer that question. And it may well be that you were directed to an out-of-hours GP, for example. Or it may well be that an ambulance is called for you to take you to the emergency department, or you're directed to a minor injury unit, or whatever they're calling them in Cornwall now. But so that's a really, that's being built up and developed as we speak. I have another role where I am a clinical governance lead for South West for that service, so I am aware of what's happening a bit more than perhaps everybody else is. But I think it's really important to just highlight that, because I think it would be really a great source of anxiety to me if I did live somewhere and I thought I only had the option of waiting till my GP was open or calling 999, because we know that people don't like calling 999 unless they think it's really necessary. as well, and that's the right thing to think about. So I just wanted to highlight that there is a lot more that is available that perhaps people aren't aware of, and we'll take that back to Cornwall as well.
Can I just make a comment as well? And it's about the funding issue, or the funding gap, as many of us describe it. I think this is something that's going to come up time and time again. But there are things that we do in the health service which have limited benefit to those patient groups that receive those interventions. And one of the ways we can really try and generate more money for our local health systems is to really examine what we do, what the health benefits are, and is that money well spent. Now, I'm a foot and ankle surgeon, and many of you here may think that there's things that I do which don't really benefit the wider population when we've got patient groups who really need urgent care and interventions, such as patients with diabetes and lots of chronic conditions. So that's one of the things we're working together with across the peninsula, and that includes Cornwall. I was at the St Austell STP meeting yesterday with other clinicians talking about how we combine our efforts and really look at concentrating on those areas that need investment and improvements in services, and maybe those areas which are deemed not to give the benefits which we as patients would expect. But the funding issues is a very emotive topic, so thanks for bringing it up. And it's one that we're very aware of. And we'd love more money in the system, but there are some things that we can do locally as providers to generate more money and spend it better.
Okay, just to, before we leave that point, it's quite right that you should make it, madam, and that you should raise the question. But it's MPs and the government who decide on those funding allocations. And as you rightly pointed out, neither us in Healthwatch can campaign about it, nor indeed can any of the organisations involved in this process.
I hope I don't need it. Okay. Oh, yes. Frank True, I work with the Patients Association and a number of other organisations. Really, your talk leads into a reminder that we've come down from NHS England, a diktat that says you can't close any more beds until the services are in place to provide that service in the community. Now, that's very reassuring at first glance, but we are used to smoke and mirrors, and I'm still wondering how you're going to get the money to improve the community services to the extent that you're reducing the demand on hospital beds, given the waiting list that you have at the present. And just to follow on from that, in Cornwall, we are far behind you in terms of getting the STP together and the commissioning. You are ahead. We are totally dependent, 27% of us in Cornwall, on Derriford Hospital. I think we're very lucky to have Derriford Hospital. It's a very good hospital. But I'm wondering what the effect, I understand that commissioning from Cornwall is going to be per referral or per procedure. And that seems to me that it could create difficulties for patients, but it could also create difficulties for Derriford in knowing what the provision has got to be. I'd like to comment, please.
Thank you for that. I'd like to answer the question in relation to the Simon Stevens comment and having assurance that we have community services in place to manage an alternative to a hospital bed, because I think that's clearly a very hot topic at the moment. You'll know that us as a health community and as a CCG have been consulting on the number of community beds in the east. We've had that in the north. It's something that's very much in focus. So we actually really welcome the statement from Simon Stevens around the pillars, because I think it demonstrates that unless you really do have a credible plan and an alternative in place, you simply can't do it. And the simple reason why you won't be able to do it is because no matter what you put in place, patients will find their way to 999 or to an A&E system. So we have been very ambitious in Devon in relation to those plans, particularly in the north and the south of the patch. And they have really demonstrated by where they have looked at shifting their staffing, their resources from inpatient hospital settings to community settings, it is having a real benefit. It's stopping people going into hospital, and then when they are in hospital, they're leaving much quicker, much quicker in some instances. Where we think we've got to do more, and where we run into problems, is that those community services aren't obviously just health provided services. They're intrinsically linked to the local government and social care services. And whilst we've got really good integration in different ways across Devon, there is some duplication and there are still some deficits in the way that we provide that community-based care. So we've got to do more to bolster in some areas, and I would say some are more prepared than others to be able to make that move. But the learning that we've had from the changes we've already made put us in quite a good position, and where we have made those changes, we've performed pretty well nationally around some of our access standards particularly. So it's really been a benefit for us. Capturing the patient experience is something that we don't do very well. I think everybody knows what happens in a hospital bed. When you're in your own home and you see lots of different people coming in and out, I think it's a different experience, and we probably need to do a little bit more around capturing that. And I think you had a question in relation to Derriford as well.
So I think what we do need to do is just align some of the plans that are coming out and are being developed, not yet fully developed, as you've highlighted, around the Cornwall STP with the Devon one, because Derriford Hospital sits right in the middle of both, as well as the local community and primary care services. So we need to make sure that they're aligned, and that's work that we still need to do. But I think the important thing is that we are engaging with the Cornwall STP. We're sharing the same criteria here. We've offered that to them. So we know at the very early stage the things that we're working on. What we do need to do, though, as you've said, is make sure that at the end of this, we've got patients in the right place to meet their needs, to get the right type of support and outcomes, and that we do that with the money that we've been given to do. That's got to be our, bringing all of that together is really important.
Okay, anyone else on this table? Or shall I move to the two at the front? Right, lady here.
Okay, hello, I'm Jan McFarlane. I was a GP in this area for 27 years. And my questions are primarily about hospital beds, the number of, bed occupancy, and issues around that. So my understanding of the Devon STP is that you're going to have 600 less beds. Is that right? 400 acute and 190 community less beds.
So the STP is quite explicit. It says that in our beds at the moment, we have up to 600 people across the whole of Devon who are in beds who aren't there for a medical reason. They're there for a social care reason or an ongoing care reason, but they don't actually need a doctor to be seeing them in a hospital bed. Okay. So there is that opportunity there.
So does this mean that this is your plan to reduce by that number?
Not necessarily, because what is happening at the moment is that whilst you have those 600 people occupying 600 beds, we cannot bring 200 or 100 or 300 or even 500 people in for their operations. So we are cancelling people.
Oh, so it's keeping the beds but shifting those people out.
So we will have to change the way the beds are used so that the capacity in hospital is for people who are needing hospital care, and for those who don't need it are cared for in the community. So some of that capacity absolutely has to be used for patients who need surgery and patients who should be having medical intervention.
So I've got it wrong. You're not closing beds? You are closing beds?
We will be closing some beds because we probably don't need that number of beds for all of the surgical capacity. Okay. And we know that some of the services within some of the beds now, we've already started that in Your Future Care in the eastern part of Devon, whereby those beds can be provided in a different setting and that care can be provided in a different way.
So sorry, I'm still not clear. How many beds are going to be closed?
So we are working through a plan around 600 patients who are at the moment in beds that they shouldn't be. We've started this...
Yeah, I did get that.
Yes.
But how many beds are you going to
So we are
close?
working that out now. And we've started this year within the eastern part of the system. There are 72 beds closing there in the community. The acute system in part of the east and the north system have also been able to close some of their acute beds because they haven't needed them.
Because the provision is already there in the community?
They've been able to invest into the community, so they haven't needed to. We've not had that in Derriford. I think it's fair to say they've not been able to make that change. So this is a 4-year plan. So year on year will determine what more opportunity we have to go at. But the primary aim is to be able to manage patients who don't need to be in a bed in the community, but to make sure that the beds that are left can accommodate people within the access targets that are set to us nationally. Okay. So that doesn't necessarily mean 600 bed closures.
Okay, thank you. I have a number of questions, if you will bear with me. I'd like to ask a few more. So I understand that a third, I think it's a third of hospital beds have already gone in Devon?
Sure, it's a third. There's a figure of up to a third within community hospital beds in Devon, but not acute hospital beds.
So a third of beds have already gone in the past 4 years.
In the community.
There's 72 about to go in East Devon, and then there's going to be further closures. So are the ones that are gone Halsworthy, Oakhampton, Honiton, Seaton, and Whipton? Are those where your 72 are?
No, so Halsworthy has not closed.
It's going.
No, there is a temporary problem in Halsworthy that is being managed. The beds that are closing are in East Devon. The 72 are across East Devon. They are the areas which will be closing, not Halsworthy.
And there's Dartmouth, Ashburton, Bovey Tracy and Paynton?
So they are outside of our New Devon responsibility, but they are the beds from South Devon CCG, yes.
And 35 acute beds in Torbay?
Torbay have been able to close some acute beds. Yes, they've been able to flex their capacity down. When you're in an acute hospital, if you have an empty ward, it's a ward in a hospital, so there is fluctuation, and we need beds sometimes in the winter more than you do in the summer. Yeah. And all of the trusts are looking at their opportunity for that. So both in South and North, they've been able to flex some of their beds in that way. So they've not needed 30 beds all of the year round, but then they have needed some additional beds within the winter period.
I must say that I'm very concerned about the number of beds going. It seems to me that you lay out a very clear case for the challenges that you are meeting. Ageing population, increasing complexity. Now, I would have thought an ageing population might need more beds rather than less. And certainly, whether it is best for people to be at home where they can be at home, but a third of beds less seems massively overkill. And I think we all just have to be worried if this is safe. Professor Brian Jarman has said today or yesterday, I think, 15,000 excess deaths in the past 4 years because of problems within hospitals. And Professor Dorling from Oxford University has said 30,000 excess deaths since 2015 because of deficiencies in the health and social care system. So these are deaths. These are serious consequences because, and if you get it wrong, that's what's happening. In 2015, we had the first rise in age-adjusted death rates since about the 50s, really. There was a blip in the 60s. I think there was a specific reasons for that. But death rates went up in 2015 by about 5%, and that's 30,000 people. So this is not theoretical. I have some more questions.
Well, you've had 10 minutes already. Nobody else has got questions.
Well, these are serious. These are serious matters. This is deaths.
One moment. Can I just ask how many more people want to ask questions in the time that we have available?
Yep.
Okay. And then I'll come back to you, or unless you want to finish first. But we are approaching the end of the time for questions.
add something just on that section, because I think, sorry, I don't mean to stop you from asking more, but I just think what you've said is really important about the shift in beds, because again, I think that's really, really important that we work that through, because it's so key that we get the right services and the right type of care, and that is really difficult to predict, which is why it's so important that the criteria we've set up, that you all feel individually and collectively that they cover all the things that you're concerned about. And I understand why we get really focused on beds, because they're something that we can see, we understand, yeah, absolutely. But the other thing that we're trying to do is to make sure that if you're in a hospital bed at Derriford, that is the most appropriate place for you as opposed to anywhere else. So it's also important that if we're redesigning alternatives, then we need to know that it is evidence-based and it is best practice, because the other side of it is where we've got at the moment a high number of patients who can safely, appropriately be treated somewhere else. We are cancelling patients. And again, the risk, the upset, the disruption, all of those very human things are really significant. And that's not right for people who need our services. And we're trying to fit them into the capacity that we've got.
I'm going to move to the lady on this table now. Yeah, well, madam, I did point out you've already had 10 minutes. And could I also say that this is not the end of the process, it's hardly the beginning of the process. The rest of the afternoon is going to be for any further points that you feel need to be fed into the process, and well, I'm not looking at you in particular, I'm saying that to everybody. They will be noted by those people who are supposed to be doing that role on the various table discussions that are about to take place. If those don't need the time, then we can come back towards the end of the total period of time and have more questions and answers. But it's also, Madam, you... Yes. Those points have been made already and therefore have been noted and fed into the process. As you've already heard, this afternoon is actually about the Acute Services Review. It's about the priorities that should inform that, and within the Acute Services Review, there are actually no specific proposals at the moment. I'm now going to turn to this lady who wants to make a different point.
Thank you. My name's Joan Heaton. I come from Launceston as well. I'm not a health professional. I'm a parish councillor, and I came across the STPs at the Community Network Panel meeting in December. And quite frankly, I was confused. I couldn't quite grasp what was going on. And so I did a little research on it, and I asked a few questions. I felt very sorry for the girl who was trying to explain the STPs to us. And she did say it was full of jargon, and that's inevitable. I do understand that the NHS has massive problems with funding, and something has to be done. But from a grassroots level, I just want to say how worried we are in Launceston, and we haven't been doing too much in Eastern Cornwall anyway about STPs and getting to grips with it. I have asked our 3 county councillors in the Launceston area to bring it up at County Hall in Truro. They did not do so, although other people did in Truro. Councillor James, Councillor Olivier, Councillor Burden also. And we're really grateful for that. My town council, in February, I asked for a public meeting because I just felt lost. And I wasn't alone. Many people were lost and confused and upset and worried. And the town council did have a debate on the STP, although, again, we didn't really understand what was going on. And one councillor had read through the literature and said it was woolly. And I particularly think it's amateurish. I think the wrong question, I did the online survey, I thought the questions were not appropriate and wouldn't really lead to any positive outcome. But we don't know anything, we're just the users, and we expect you to be the experts and guide us. I called for a public meeting in Launceston Council. The motion was passed. We are having a public meeting. We think it might be April the 4th, but we don't know yet. And I'm still trying to move that on. Whether it will do any good, we're grasping at straws. Our problem in Launceston is it's such a long way to go to Derriford. And I know that to my cost because my husband has chronic issues and we have to go to Derriford a lot. And I'm always grateful when there's a clinic at Launceston Hospital, one of the regular clinics. And I'm hoping that Launceston might be one of these hubs. And we're keeping our fingers crossed. But that's all I want to say. Thank you very much for listening.
Who would like to respond to those points?
So I suppose, first of all, has anything we've said so far this afternoon made things any clearer or not yet?
Sorry, but I think you don't know where it's going.
Yeah, I think you're right, and you know, one process won't fit the whole country, and we're trying to use one recipe across each sort of county area. I think what I have seen in the last 12 months is a much closer working relationship between all of the acute providers, the community providers, the community groups, and whereas before maybe we sat slightly in ivory towers, and that's not a criticism, just saying that each provider, each network was slightly isolated. We now work much more closely across secondary and primary care, across the commissioning groups, across the other acute provider trusts, and that was testament yesterday when I was down in St Austell talking to RCHT and the Cornwall community groups. So I think you're right, there are some areas we don't fully understand. One size doesn't fit all, but at least we're asking the questions and working across networks together, and we will start to change how we provide healthcare and how we design those frameworks. And just one example which might sort of cross a number of questions, for instance, we could open more beds at Derriford, but we couldn't staff them, we couldn't safely staff them. And I think that's really important to recognise, is even if we had more beds, currently we couldn't find the staff to provide safe levels of care. Yet, if we now work in collaboration with our community partners in diabetes, for instance, where our consultants go out into the community, work closely with GPs and primary care, and start to integrate the care between primary and secondary care, we'll hopefully prevent some of our patients being admitted to Derriford because we're better caring for a chronic condition in the community that may avoid a hospital admission, for instance. And we've already started that across a number of domains, and we're seeing some early results.
Just wanted to add about the hub point, because I think that there's clearly a lot of focus on community hospitals as beds, just beds, but actually what we've learned from the facilities is they're much, much more than that, and you can certainly do much, much more than that with them. And in thinking about what we've just heard in terms of working across services, we've seen in some of these facilities whereby the acute hospital is looking to outreach to the community and have clinics there, and to think about different access mechanisms, and to really start to bring hospital-based care that's been traditionally in one part into a different focus in more rural areas, and of course here and in other parts of Devon, Oakhampton, Holsworthy, all that area had such a good case for thinking about that way of working, and that's absolutely in the mindset. I know it's in the mindset of our colleagues in Cornwall as well, and Somerset. It's our unique geography that means we have to change in that way.
Okay, right. We now need. Right.
So I can't comment on the Cornwall community hospitals, and if it's not a community hospital, we need to remember there are GP practices as well, and there are also virtual hubs.
Right. I don't think we're going to get very far at all if we're just sort of shouting at each other across the room. The time for questions has now been extended by at least 10 minutes. We need to move on to the table discussions. And as I said to the lady on this table, if that leaves us any time at the end for further questions and answers, then that is what can be done. So what we need to do next is to think about the 7 priorities of the STP and how would you want to be involved in the plan over the next few years. And then specifically in relation to the acute hospital and specialist services, the acute services review, are the evaluation criteria the right ones, and what is important for you about each of those criteria. If you feel you want to emphasise a point that's already been made by one of the questioners, then please do so. If you want to raise a different point, then I'm sure the facilitators who are about to make themselves known to each of you on the tables will make sure that they record that just as much as any other point that is being made. So over to the 4 tables now for that discussion, and then a few more questions at the end. I'm sorry to make this announcement, but we are now very near the end of our scheduled 2 hours, coming up to 4:30. So could those of you who are facilitating on the tables please draw whatever conversations are happening, very good conversations I'm sure, draw them to a conclusion, and we'll then have to start to tidy up. So thank you all very much. I've just been talking to Anne James, who's on the panel, and she has certainly learnt some significant lessons, I think, from the conversations that you've had, Anne, and we'll be feeding that back into the process, certainly for the Devon STP, which is really what this has been about